Yeah. Dear Chairman, ladies and gentlemen, it's an honor to stand here to present here something about hypothermic oxygenated perfusion to rescue futile DCD liver grafts. It's a strong word, to rescue. I will try to explain it. So this is, I start with a picture. This is the last DCD offer which I had last week, and I would like to have your opinion if you ever would accept that. Donor age, 81 years, asystolic warm ischemia time, 21 minutes, functional warm ischemia, 40 minutes, cold ischemia, 7 hours, 30% macrosteatosis. This is the reality. So the question is about these kind of DCD livers, which we get offered today. And it's a difference to the DCD livers, which I put here with the green light. So donor age below 60 years, short warm ischemia, no fat at all, short cold storage. Probably no problem. You can do what you want with this kind of livers. But if it comes to this situation, so donor age advanced, as we see it nowadays, functional warm ischemia far above 20 minutes, above 30 minutes, macrosteatosis also on board, and cold ischemia. Can we do something with this kind of grafts? And for sure, we need, for the first step, we need a risk assessment. And it's not easy to judge livers nowadays, but I put an example of a score which I like, the UK DCD score, because we see here 3 groups of DCD livers. We see low-risk groups, which are getting 5 points or less as 5 points. That is determined by 8 parameters, as you can see here: combination, donor age, donor BMI, because biopsy often not available, functional warm ischemia, donor warm ischemia, cold storage, recipient age, also the recipient situation, recipient lab melt, and retransplant, meaning primary transplant or secondary transplant. So the combination of all these risk factors gives points from 0 to 27 or 25. And you see, if you receive low points, 5 or less than 5, there's no risk for graft loss. And this was developed in the larger database of DCD in the UK with more than 1,000 DCD patients, more than we ever have in Switzerland in 100 years. And it was also validated, by the way, in UNOS. So we have 3 groups: low-risk group, high-risk group, meaning 5 to 10 points, and the so-called futile group. This is more than 10 points. So what happens in the UK and in US if you have more than 10 points? And it's also important to understand what is futile, what does it mean, because there are different definitions. Probably it is death within 3 months, or let's say survival less than 50% after 5 years. And we have to define that in the next years as a transplant community. But here you see what happens if we apply the DCD score from UK to the DCD population. You see the 5 points, the patients do well. They have, after 5 years, more than 80% survival. I said, you can probably do what you want. You probably don't need optimization strategies. No perfusion at all, probably. That's my opinion. But you see also what happens if you have more than 10 points. The patients deteriorate. More than 10 points means less than 40% survival in the first year. And that is the same also in UNOS. And even more, it is very predictive, this score, and very discriminative in terms of PNF and in terms of ischemic cholangiopathy, the most feared complication after DCD liver transplantation. So basically, if I come to the first slide, you get this offer, what you want to do. You have 2 options: decline the offer, or you do something to optimize. And therefore, we speak about machines nowadays. And you see, you have several opinions. You can pump in the donor, you can do ECMO in the donor, you can put livers on the air drive, you can use the organ recovery system. Of course, you can use Peter Friend's machine, Organox, or you can use liver assist or transmedics. It is your opinion, your decision. What we did is a very simple method, for sure very simple. We keep cold procurement, we keep cold storage, we put livers from the quality which I have shown you on an end-ischemic, hypothermic, oxygenated perfusion procedure. We have done so 74 livers, DCD livers, in the last 6 years with implantation, and the reason to do that is a very high donor warm ischemia in Switzerland and also advanced donor age, as you see here, 40% above 60 years, and long functional warm ischemia time. So the reason to do that was to give that organ to HCC recipients with a very long expected waiting time, and to have some hope for the patients that they get transplanted. This is the example of some livers which you see here, and if you apply now the score, you will see later that all of these grafts, in fact, have more than 10 points, most of the grafts. So 40% of these grafts have more than 10 points if we calculate the UK DCD score. And now the aim was to show you or to observe the results of the so-called futile classified DCD transplants, which we did in Switzerland. The endpoints we selected were easy. We were not interested in AST or ALT in the first week. We were interested in post-operative complications within the first year. We think this is the most relevant in the clinic. We were not interested in tumor-related graft loss, but in non-tumor-related graft survival. So this is the results. You see here, donor age 62 years in median. You see many patients above 60 years. You see the donor BMI above 25. Median is 27. You see the ICU stay after transplant, which was 4 days. You see the warm ischemia. This is 38 total, 36 functional. This is asystolic, 19 minutes. This is the cold ischemia. You see that we keep cold ischemia short, below 6 hours, one of the strategies. You see also that we implant these livers in low melt recipients. This is a second strategy. We don't select for these kinds of grafts high-risk patients. You see the recipient age, and you see the score. 11 points UK DCD score in median, and you see also the other scores which are on the market, the donor risk index and also the DLI, and our patients qualified far above suggested thresholds, as you see here in blue. So this is the postoperative course or the intraoperative course, 6 hours in median. This is the noradrenaline at the end of the operation was relatively low after 1 day, no pressure in patients on the ICU. This is the lactate at the end of the operation in futile, so-called futile classified DCD transplant. This is the lactate after 24 hours. This is the liver function, INR, 1.4. ICU stay, I already mentioned. This is the peak ALT. We had no primary non-function in these grafts, 21 grafts. And this is the kidney function. You see that most of the patients delivered kidney problems in the first week, but you see that the renal replacement treatment was 24%, so 75% required no dialysis in spite of the advanced or severe graft quality. This is the post-transplant results. We have relatively low rejection rate despite use of marginal livers. This is the creatinine after discharge, fully recovered. There's the hospital stay, which is relatively long in Switzerland. I have to say the people have to stay and wait for rehab. This is arterial problems, 1 required retransplant. This is the total biliary complication, 1/3. This is anastomotic biliary stenosis, AS. This is 28%, and this is hepatocyte transporter injury, no intrahepatic cholangiopathy so far. You see here the bilirubin course within 1 year. This is 10 points, bilirubin after 1 year. You see here the alkaline phosphatase and the gamma GT after 1 year, and you see that the kidneys also fully recovered within 1 year. And this is the survival of 21 so-called futile classified patients, which is at the moment 92% after 5 years patient survival and 86% graft survival after 1 year. And this is strongly in contrast to what was published in futile livers without treatment, without machine treatment. You see here what happens. This is without treatment. You see the discrimination, more than 10 points, 40% survival. If we apply machine perfusion after cold storage, the difference between the 3 groups disappear. Yeah, of course, we need to compare the results in a randomized trial, which will come by Robert Korte, HOPE, perfusion after cold storage versus no treatment. This has to be, of course, compared in randomized trials. And the question comes, is there a limit? Can we do the same with every kind of liver? Is there a limit if we apply machine techniques? For sure, no. So the decision to accept DCD livers in the futile range need to be based on metabolic assessment. This is just an example of what you can do nowadays. You can measure a lot also during cold perfusion, not only during warm perfusion. This is just a metabolomics assessment. You can measure more than 1,000 proteins. The question is, which of those proteins are relevant? And the mechanism is a lot behind. So we know we change the cellular battery. We upload ATP within 2 hours if we apply end-ischemic hypothermic oxygenated perfusion in grafts. And we think that makes a difference because lots amount of ATP means, at the other side, low amount of released reactive oxygen species. This happens if we apply hypothermic oxygenated perfusion, and this happens if we don't do it. So huge amount of reactive oxygen species and low ATP, and that results in organ injury. Thank you very much.